Good afternoon, everyone. I would now like to call the meeting of this National EMS Advisory Council to order. Thank you, representatives, for joining us for the first round of the meetings of the 2023 session of NEMSEC. My name is Mary Ehlers, the EMS Education Sector's representative, and I am honored to serve as NEMSEC's chair and moderator today. For those joining us virtually today, we'd like to extend the warmest of welcomes. One of NEMSEC's lessons learned during the pandemic was the council had more public involvement when the meetings went virtual. To promote continued public involvement, we've decided to hybridize the NEMSEC meetings so that we may resume live meetings in Washington, D.C., but also invite the public to join us in the virtual space. Per usual, our meeting will proceed with the following agenda. Representatives, please always remember this is a public meeting and to hold your questions or comments until the floor is open for discussion and the chair or the vice chair recognizes you. At the designated time during our agenda, the floor will be open for questions and statements from the public during the public comment period. In the event we are addressing an item of business when the public comment period is upon us, we will ask that our discussion cease to allow the public comment period to proceed. Now let us begin with our first order of business, introductions of the NEMSEC representatives and their disclosures of conflict of interest. The chair would like to recognize Dan Wijatonga, from Director of the Office of NETSA of EMS.
Thank you, Madam Chair, and welcome everyone. I'd like to, formally welcome everyone who's here with us in DC and everyone joining us online, both members of the council and members of the public. Just a reminder to members of the public, if you have comments or questions as the council meeting is proceeding, please use the live chat feature so we can hear what you have to say during our time on the agenda for public comment. We appreciate that. Members of the council, I'll state the name of each sector of EMS representative, and when I call out your sector, please unmute or activate your microphone to introduce yourself by name, location, and then please declare any conflicts of interest you may have. All right, so let's kick it off. EMS educators.
Mary Ehlers, Cincinnati, Ohio, no conflicts of interest.
Thank you, Madam Chair. EMS quality improvement.
Yes, Jonathan Washko, New York City, Long Island, New York, no conflicts.
Thank you, Mr. Vice Chair. Next, we have volunteer EMS. That position is currently vacant. State EMS directors, that position is currently vacant. Air medical EMS.
Ryan Walter, Gilbert, Arizona, and I have no conflicts to disclose.
Thank you. EMS medical directors.
Hi, Peter Talak, Salt Lake City, Utah, no conflicts.
Thank you. Emergency physicians.
Dr. Bradley is on call.
Okay, we'll come back then. Pediatric emergency physicians.
Kathleen Adelgaze, Golden, Colorado, and I have no disclosures or conflicts of interest.
Thank you. Public safety answering point call takers, dispatchers, 911.
Sherry Bartram, Michigan. I have no conflicts of interest.
Thank you. Emergency nurses.
Matthew Powers, Pleasant Hill, California, no conflict of interest.
Thank you. Emergency management.
Lori Knight, Seymour, Tennessee, no conflicts of interest.
Thank you. Fire-based EMS.
Lillian Bonsignor, New York City, New York, no conflicts.
Thank you. Private EMS. Okay, we'll come back. Hospital-based EMS.
Afternoon, Paul Brennan, Lawrence, Massachusetts. No conflicts.
Thank you. Tribal EMS.
Dr. Kohler, Alaska, no conflicts.
Thank you. Local EMS directors.
Lisa Basgall from Houston, Texas. No conflicts of interest.
Thank you. Trauma surgeons.
Mark Estring, Rochester, New York. No conflicts.
Thank you. State highway safety.
Alicia Sledge, Diamonddale, Michigan. No conflicts of interest.
Thank you. EMS data managers.
Tal Harkins, Indianapolis, Indiana. No conflicts.
Thank you. EMS researchers.
Jason Sullivan, Cincinnati. No conflicts.
Thank you. Hospital administrators.
Brendan Hayden, Portsmouth, Rhode Island. No conflicts.
Thank you. Public health.
Carol Jorgensen, Elm Creek, Nebraska. No conflicts of interest.
Thank you. EMS practitioners.
David Pfeiffer, Powell County, Kentucky. No conflicts.
Thank you. Legislators. Okay, we'll come back. Consumers.
Dr. Ayo Ogunsola, no conflict of interest to declare. Thank you.
Thank you. And we'll just go back real quick to some we might have missed. Emergency physicians, Dr. Bradley, are you on? Or is he in?
He's, I believe he's on a call he had to take, so
Okay.
he's here.
Got it.
And then David, the private EMS physician will not be on.
Okay, got it. And just one last check for legislators, Sue Prentice. Okay. That concludes the roll call and declaration of conflicts. Thank you, Madam Chair.
Thank you, Dan, and thank you, representatives. Representatives, you should have had time to review a digital copy of the summary of the last NEMSEC meeting. Are there any corrections or amendments to the record?
Madam Chair, there's no one indicating as such in the room.
Thank you. Hearing none, all those in favor of approving the record, please unmute and say aye.
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 Anyone opposed, please unmute and say nay. If abstaining, please indicate now. The motion passes. Moving on to the FICOMS update, the chair recognizes the 2023 FICOMS chairperson, Nanda Srinivasan.
You got it almost right, Madam Chair. Thank you, Madam Chairperson, for this invitation to join the council meeting today. FICOMS, as you all know, is established in 2005 to ensure coordination among federal agencies and supporting local, regional, state, tribal, and territorial EMS and 911 systems. It was also established to improve delivery of EMS throughout the nation. We met in December 7, 2022. I'll give you a brief rundown from what was discussed at that meeting. From the Health Resources and Services Administration, ASPR Tracy reported that they created a website to respond to surges in respiratory illnesses at pediatric hospitals. The website provides a resource library, assistance center, and peer-to-peer information exchange hub. EMS for Children's Innovation and Improvement Center launched an EdStop Suicide Quality Improvement Initiative in January. EMSC starts issuing grants to states and accredited schools of medicine to support its expansion of access and to improve quality of emergency care for children. The Assistant Secretary for Preparedness and Response, ASPR, was represented at the National Health Coalition Preparedness Conference and shared that their members of the EMS community are eager to collaborate. They also reported disaster preparedness community that has embraced EMS as an integral part of U.S. response to the pandemic. The Centers for Medicare and Medicaid Services reported that they're reviewing guidance provided to healthcare system as operations become more typical following the COVID-19 pandemic to determine if flexibilities should continue, become permanent, or end. Providers will have about 60 days notice before changes are implemented. CMS is also collecting data from ground ambulance providers to be stored in the Medicare ground ambulance data collection system. Data collection began on January 1st, 2023, and most agencies will have a 12-month continuum to submit data electronically. CMS will report findings 5 months after the data collection period ends. A list of agencies selected to participate in Year 3 and Year 4 was posted on cms.gov in December 2022. The Office of Health and Security in the Department of Homeland Security reported that they have 3,700 EMS practitioners with staff located in urban, suburban, rural, tactical, and austere environments. EMS division of DHS has oversight of 7 expanded scope of practice modules, including advanced wound care, clinical medicine, canine care, hazmat, and austere paramedicine. DHS is engaged with immersion training through partnerships with strategic facilities, trauma centers, and academic institutions. This initiative is part of the DHS quality improvement process designed to help DHS EMS practitioners meet or exceed performance standards. The United States Fire Administration, USFA, the EMS brand support was to be added to USFA to support mission and vision states around EMS specific activities. They performed a gap analysis to better understand existing gaps in their ability to carry out congressionally mandated mission. Results will inform any necessary mission updates. They also received stakeholder feedback from FEMA about the lack of EMS engagement in disaster preparedness and planning. USFA is to further engage with FEMA to discern ways to collaborate more effectively. USFA is also developing several programs, handbooks, guides, and manuals, including the Handbook for EMS Medical Directors, the Retention and Recruitment for Volunteer Emergency Medical Services Manual, and programs for Civil Unrest Program and road or highway safety. Department of Transportation, NHTSA, we welcomed Ann Carlson as the new acting administrator of NHTSA. And last Friday, I guess, she was nominated by the president as administrator, nominated as administrator of NHTSA. So she'll be going through a confirmation process. Acting Administrator Carlson advised FICOMS that NHTSA was working with its federal partners to address challenges of the EMS community. We understand the 24 to 36 month production time for new ambulances and the workforce shortages that have been reported. We discussed input received from NEMSAC regarding the National Roadway Safety Strategy implementation and highlighted key issues. Again, thank you for that work. I think collaboration among 911 EMS and trauma systems is critical. Adoption of best practices in EMS care, as you indicated, extremely important. And there's an ongoing need to support continuous quality improvement, which was recognized in your memo. The research projects underway in various areas include NEMSIS work, 911 research work in advancing EMS systems. We are also focusing on saving lives post-crash by supporting EMS resources, collaboration, and providing educational programs. We recognize EMS as you all know, as an integral part of our National Roadway Safety Strategy, and that will continue going into year 2. Especially with respect to rural safety and EMS activities, I will be looking for some ideas and focusing on some actions. DOT and NHTSA asked all EMS providers to update guidance to include information about hazards of high voltage batteries in each state of an event response, prevention or preparedness pre-event, response or mitigation during the event, and response and recovery post-event. The mental health of EMS and 911 workforce continues to remain a huge priority, and OEMS work with the White House Interagency Policy IPCs on 988, crisis response, and public awareness campaigns continues. I'd like to point out the work of Kate Elkins here. Thank you. OEMS is also collaborating with CDC and National Institute for Occupational Safety and Health, NIOSH, to research the rate of first responder suicide and overall mental health of the EMS and 911 workforce. On the next generation 911 front, a roadmap published an outreach report, and we are conducting a GIS and CAD assessment to determine optimal ways to establish a national 911 program. The webinars continue providing updates to states on 911 issues. The Federal Communications Commission reported their primary mission to focus on areas, improvements in communication systems that support EMS response with a focus on the 911 system. Calls may be directed to PSAPs based on the closest cell tower to the call rather than the location of the caller. In December, FCC began considering proposing regulations that would require wireless carriers and text providers provide 911 calling routing information based on the specific location of the caller, eliminating the need to reroute millions of calls to different PSAPs. It's a big deal. A public draft of the regulation was posted on fcc.gov. State EMS directors at the Joint EMS Leadership Forum in October 2022, an important topic of distinguishing EMS as an ESF, shortages in drugs, ambulances, and PPE, reemergence of infectious diseases were all discussed. ONDCP created a national dashboard for non-fatal opioid overdoses using state EMS data. Thanks to the database that we created here, NEMSIS, for all the improvements there. NESIMSO is also involved in various projects, including airway management, EBG, standardizing state data reporting, standardizing data dissemination through quality metrics, examining EMS practitioner health, wellness, as first responder suicide rates continue to increase. With that, Madam Chair, may I hand this back to you? If there are any questions.
Thank you so much, Nanda. The chair would like to now recognize Gamwe Jatanga, Director of the NHTSA Office of EMS, for the National Roadway Safety Strategy Post-Crash Care Update.
Thank you again, Madam Chair. So in 2021, 42,915 people died on America's roadways, and approximately 40% of those fatalities occurred after EMS arrival. A 2016 report by the National Academies estimated that 20% of injury deaths are preventable with effective trauma systems of care, and that the greatest opportunity to save lives is in the pre-hospital setting. As the Council knows, we recently passed the one-year anniversary of the National Roadway Safety Strategy, which set a goal for eliminating roadway deaths and injuries using the SAFE system approach, focused on safer streets, safer roads, safer people, safer speeds, and post-crash care. I want to thank the Council for your advisory letters issued to NHTSA and FICOMS back in November on how to improve post-crash care. As you know, the National Roadway Safety Strategy is energized by unprecedented funding through the Bipartisan Infrastructure Law, and it represents a unique opportunity for us and our FICOMS partners and our partners throughout the nation to holistically advance 911 and EMS systems and address this crisis on our roadways. We've been taking a close look at your letters, and in particular their focus on the role of emergency medical dispatch, timely on-scene care using EMS clinical guidelines, triage and transport using the National Field Trauma Triage Guidelines, and of course the importance of continuous quality improvement through data linkage, education, and sustained collaboration. Just in the past few weeks, just in time for the one-year anniversary of the NRSS, NHTSA published a final rule on the triennial highway safety plans, which state highway safety offices will be submitting to NHTSA later this summer. As we speak, NHTSA, through our regional operations, is conducting webinars with highway safety offices and their partners, giving an overview and answering questions about what will be included in those triennial highway safety plans. And I think as the Council is aware, the EMS and 911 and trauma communities were very active in providing comments on that draft rule, so we appreciate it. Also, just within the past few weeks, the Federal Highway Administration, our partner agency, announced the first round of $800 million in grants going out to 510 communities in the country under the new Safe Streets and Roads for All grant program created by the Bipartisan Infrastructure Law. That grant program, known, the shorthand is SS4A, provides a new funding stream of $5 billion over the next 5 years for improving road safety at the local and regional level, and of course adopts principles of the safe system approach. So I encourage you all to stay on track of that program as it advances. NHTSA recently entered into an interagency agreement with the U.S. Fire Administration focused on how we can eliminate struck-by incidents on the roadways. Thanks to data provided by the Emergency Responder Safety Institute, which is reportstruckby.com, we know that from 2019 to 2022, there were 205 fatal struck-by incidents in the U.S. This included 82 law enforcement officers, 33 fire and EMS clinicians, 6 road service workers, 6 DOT workers, 4 mechanics, and 74 towers. It's obviously a priority under the NRSS in addition to improving EMS systems that we eliminate these preventable incidents. We'll have more on this interagency agreement between the USFA and NHTSA and our partners in the very near future. We're literally just completing the paperwork for that. So we're very excited about that collaborative opportunity. Also, just another update on things that have gone on. Just in the past few months, NEMSIS, the National EMS Information System that's administered by NHTSA with our state and local partners, now has a public traffic crash dashboard. We have a link to that on ems.gov as well as on nemsis.org, and it incorporates crash-related data from all 50 states, 3 territories, and the District of Columbia. It's an important source of crash injury information that at the national level we haven't had until now. I mentioned that we have more than 42,000 fatalities in 2021, but thanks to NEMSIS, we know that the nation's 5,400 PSAPs dispatched EMS to over 1.4 million crashes in 2022, and that EMS treated nearly 165,000 seriously injured people in those crashes. So it gives us a much more detailed and near real-time look into what's going on in terms of crash injury in the United States, and we hope to utilize that data to greater effect in the coming years. So a lot of ongoing activities associated with the National Roadway Safety Strategy remains a major focus of our agency, in addition to supporting EMS and 911 system improvements across the board, and we appreciate the NEMSAC's engagement on this issue. Madam Chair, happy to entertain any questions.
Council members, do any of you have any questions for either of our speakers?
Madam Chair, there's no indication in the room of any questions. Oh, I'm sorry, Dr. Adelgaze.
Thank you. Thank you both for those reports. I did want to follow up on the issue of crash testing of pediatric restraint devices for ambulances. It sounds as though that is something that kind of had gone through an initial possible approval process, but then has been held up in the funding. And I just wanted to get an update on some of the discussions and rationale for that, because we're discussing issues around the safety of providers on the road, the safety of providers in lights and sirens, and the challenges in getting EMS providers to not transport in that manner, yet we still have it yet. And we also have a huge number of new devices on the market that EMS agencies are purchasing, thinking that they're safe for children, but there's no evidence around that.
No, thank you for that question. We are continuing to work with our vehicle engineering side of NHTSA on that project. I don't think there's been any holdup in the funding of that. It's frankly just a matter of paperwork at this point, just to be perfectly honest. So I still expect the project to proceed.
Awesome. Thank you.
Any other questions? Madam Chair, no further questions from the room.
Thank you, Jonathan. At this time, we'd like to take a short break and allow our committee chairs to prepare for their presentations. So if we all could return at 14:40, that would be wonderful. I would like to welcome everyone back from the break. We have now come to the subcommittee reports portion of our meeting. During this time, we will hear from each subcommittee chair, who will provide an advisory update for the council. After each subcommittee delivers its update, we will open the floor for the council at large to ask questions of or provide feedback for the respective subcommittees. The chair would like to recognize first Lori Knight and the Adaptability and Innovation Subcommittee.
Thank you, Madam Chairwoman. The Adaptability and Innovation Subcommittee is still in the research phase of an advisory regarding the designation of graduate prepared paramedics as federally recognized practitioners. And to discuss this further, I'd like to hand the floor over to the Vice Chair of the subcommittee, David Pfeiffer, who has been putting pen to virtual paper on this.
Yeah, thank you. So it may have been a little bit overly ambitious in meeting this deadline for more public discussion of it. The issue is, a little complex. It continues to evolve, and we continue to get some new information that's relevant, such as New York State's Vision 2050 or Agenda 2050 that calls for master's degree prepared advanced practice practitioners. So we continue to incorporate that sort of information from trends and other initiatives that we see around the country, and continue to develop the idea. A lot of good discussions still occurring, and then I think that we will have a draft for public consideration at the next meeting.
Thank you. Madam Chairperson, back to you.
Would anyone have any questions or input for either Mr. Pfeiffer or Mrs. Knight?
Madam Chair, there's no indications for questions.
Thank you. The chair now recognizes Jonathan Washko and the Sustainability and Efficiency Committee.
Thank you, Madam Chair. So we would like to bring forward for draft consideration the revised version of the EMS system financing advisory we've been working on. This one we're looking to actually rename and call it the Annual State of EMS Financing Advisory. And this would supersede the May 2012, September 2016, and September 2019 advisories updated and completed under the name of the EMS System Performance-Based Funding and Reimbursement Model. There are a significant number of recommendations. I don't know that I'll go through all of them, but maybe highlight a few. Where one, we definitely are recommending to the NEMSAC going forward and future NEMSAC members that they look to do a couple of things. One would be to keep this advisory kind of as a required advisory that should be updated and looked at every year by the committee until we can get EMS funding fixed, which I don't know if that'll ever happen, but at least get the ball moved much farther down the field than we already do, as well as work with the Office of EMS and looking at the advisories that have been put out by the NEMSAC to understand the status, if they would be moving forward in funding, if there's prioritization that needs to happen, maybe because, of some of the things we're talking about today, but the current members are moving on. How do we look to manage some of that? So that's another recommendation. When we get into the dollar side of things, ultimately, we're trying to figure out how do we get parity between law enforcement, fire, and healthcare. Like I said, there's a lot of recommendations within that. There are things available from the federal government that can help states do this, but they're not widely known. One's called GEMT, Ground Emergency Medical Transport, which is a supplemental payment program for government providers, and then what's called a UPL, or an upper payment limit, for private providers that ultimately help through federal matching programs to cover the gap between Medicaid and Medicare, or Medicaid and the cost to provide services. So definitely something that is starting to get, I guess, some initiative and some movement. But ultimately, we're asking OEMS and NHTSA to help develop a toolkit for the industry to better understand how to implement those gap payment programs. Some of the other things we're doing, is working with the GDAC system mentioned earlier, the Ground Ambulance Data Collection System, to ensure that the underspending, and I want to make sure we understand what that means. So because of how EMS is funded and the public utility economic structure that we live in, there's essentially a fixed pool of dollars, that are available to EMS that doesn't grow when our expenses go up necessarily, doesn't grow when clinical innovations come up, doesn't grow, when we like to pay living wages. We're kind of stuck within this constrained bucket of dollars when it comes to reimbursement, at least from insurance payments. And so that then kind of trickles down, as you think about it, to underspending. So there's money we wish we could have spent, not for frivolous things, not for profit, but for making sure we've got the latest in care innovations and the latest in training and livable wages and benefits and so on. And so this advisory is basically recommending to FICOMs, specifically CMS, that they, as they go through GDAX, that they really look at this particular issue. I know it's been mentioned in other forums, but I think it's good that they hear this in a consistent message from various groups. Let's see. So definitely I'm trying to expand federal grant opportunities. Obviously the NRSS is something I think we need to pay particular attention to, and see what dollars can be used from that initiative to help out the industry at the local level. I think that sounds like there's some great opportunities, and it sounds like I wouldn't say the sky's the limit, but they're looking for ideas, and please come forward if you have things as these grants get rolled out to try to put programs in place that meet the goals of that initiative. So a couple of other things is to look to extend some of the waivers. I know some of them have already been declared as going away, but things like treat in place, transportation to alternative destination, treatment in lieu of transport, and other waivers that have supported EMS, like telemedicine waivers, for example, which are still in place, that support us, to do treatment in place, for example, is another ask of CMS under FICOMS. Definitely another one that I think is of interest when we look at the various funding opportunities for EMS is to see if CMS would be willing to categorize EMS as a safety net provider, similar to rural hospitals and safety net provision systems under the rural setting, to help financially support EMS and probably do something in conjunction with safety net facilities, especially in the rural areas. Urge, again, CMS to look at how EMS is reimbursed and stop looking at it as a transportation commodity, but actual as healthcare service and a healthcare area. I think there's an advisory coming up talking about, making pre-hospital medicine an actual area of practice, so that we can look at this from the medical perspective and not just, the current structure. We talked about gap funding. Definitely another one is Department of Labor and working with the state EMS offices to make sure, especially the rural providers, understand how to properly complete the GDAX. I know some of the associations out there, like the AAA and NEMT, I believe, have put some guidebooks out, but I don't know that there's how much education has happened, how much money has been put into educating, but definitely something that I know there's concern about, that we get accurate data into the GDAX system so we can fully appreciate where things lie. Market right accountabilities and looking at the whole issue of public utility economics and understanding the impacts of those in the communities. And then finally, actually opening up a mechanism to allow EMS to put in under the Council for Technology and Innovation under CMS for net new modalities. So anytime a new medication comes on board, or there's a new procedure that's created, or a new device that's created, it goes through a process within CMS in order to get funded. EMS has never had an ability to do that, but it's another thing, as if getting classified as a healthcare provider potentially would open up the door for new, novel EMS innovations that come up, and to provide some sort of funding mechanism to ensure that we're providing the latest in evidence-based care. So that's, I think, for the most part, it. There's more, but I won't go into all of it. And let's see if there's any questions. Chief Bongsinor.
Thank you, sir, and thank you for taking on this incredibly challenging situation. Funding for EMS continues to be by far the largest obstacle to progress, and putting everything in one place is going to be an incredibly helpful tool. I'm wondering if within your document, do you also make any kind of mention or recommendation that includes when things are changing, drugs are changing, protocols are changing, the cost of training all the professionals? I think that's another huge obstacle that's attached to funding. I'm just wondering if you included that at all.
I don't believe we specifically call it out, which is more in general, but we're happy to specify that into specific areas to make sure it's called out as an area of interest.
Thank you for your time, and thank you for your efforts.
Thank you.
Great job.
Thank you. Any other questions? Any questions online? Let me look here. Not seeing anything in the chat. So, Madam Chair, there's no other questions here. I'll turn the floor back over to you.
Thank you, Mr. Washko. The chair would now like to recognize Sherry Bartram and the Integration and Technology Subcommittee.
Thank you, Madam Chair. Sorry, I was watching the agenda and I didn't think I was up yet. First, I would like to thank the work of the committee for both advisories we are putting forward for consideration to begin today, as well as the honor it's been over the past 2 years to work with this group of individuals. I will sincerely miss the camaraderie that has been developed over time. I have great respect for and admiration for each member of the committee and the council, and serving on NEMSEC has provided me with far more than I imagined when I was initially appointed to the position. So thank you for this humbling experience. I will be introducing one of the advisories, and then I will have Tom introduce the other. The first one we're going to talk about is the data management standards. The functions of a data manager are to promote standardization and improvement of data collection. Within these functions, the data manager also must make the determination of what data needs to be collected, identify the appropriate resources, and ensure the quality of the data used. Additional functions of a data manager include making sure the data systems utilized for analysis are operational, provides access to agencies for submission and use of data. Maintained data must have methods in place to troubleshoot submissions and data and data errors. The National Association of State EMS Officials provides data manager job descriptions, provided a data manager job description in 2017 that clearly described these basic functions for a data manager at a state level. The data manager plays a critical role in supporting the life cycle and building foundations for making that data useful and ensuring the highest quality patient care is being provided. This advisory takes this into account, recognizing that a gap exists between the initial call to EMS to 911. So the 911 call to the EMS, and from EMS to hospital care. So the intent of this advisory will assist in closing that gap. The data manager helps minimize potential errors by establishing the processes and policies for usage and building trust in the data being used to make decisions across your organization. Any one of those three pieces that has a glitch could affect each of the other. Health data management is revolutionizing the way we manage patient care by improving the quality of healthcare delivery and to help reduce costs. The same data that offers us opportunities presents challenges as how we can keep medical information accurate, updated, and secure through the process of collecting, storing, retrieving, transferring, and protecting the data. Our audience for this advisory would be FICOMS working with NEMSIS as they provide the framework for collecting, storing, and sharing standardized data, which makes them appropriate for this advisory. The goal of the advisory would be to provide federal guidance for standardized requirements for the function of a data manager from 911 to EMS to the initial hospital care. The committee will be providing recommendations to FICOMS to provide data manager job functions that span the complete EMS response, again, from the initial call to hospital and the data that follows the patient. So we respectfully ask for this committee to consider approving the further research into this topic to take this forward. I don't know if we pause there. Our next advisory, I'm going to turn over to Tom to present. As I believe he may be. Well, I'm going to just leave that. Okay, go ahead. Thank you, Tom.
All right. Thank you, Sherry. Thank you for your work in helping us guide this committee. Vice Chair Washko had actually asked us to start looking at this. It's the impact of Public Law 11583 on EMS providers, referred to as Protecting Patient Access to Emergency Medications, the Act of 2017. It was put in place in 2017. It's just now coming to fruition. What it is, it used to be that paramedics could only give a narcotic under the law if a physician was standing there or if there was a prescription written for that patient. Obviously, in the out-of-hospital setting, that doesn't always work, so we were really kind of practicing outside of the DEA regulations. They've changed the rule a little with the help from Dr. Brent Myers and the NEMSP group. They rewrote it to actually make it more user-friendly for EMS, but it does come with some other things that we need to be aware of. Some licensing issues and some how narcotics are stored and where they're stored at, who needs to get them, how's it cross state boundaries, those types of things. But the problem is they've not made it really clear unless you actually read the law. And unless you're a lawyer, some of the law gets kind of confusing sometimes. So we'd like to work with FICMS and NACIMSO to create some standardized guidelines and education and training that will help support this law and actually enable EMS providers to follow it correctly, make sure that we're doing all the right things, and create the least administrative burden possible doing this process. So ideally, it would be posted on each of the state's websites that an EMS provider could go to. Here's my state, here's my local contacts, who do I need to talk to make this law work? What questions do I have? Some frequently asked questions from the DEA, from the actually does it impact any state laws, things like that. So by putting this recommendation together, we're hoping to close that kind of gap of making this a little bit more accessible and easier to understand for everybody who is not living in the legal world and understands what all the different laws are, plus make it easy to find. So that's another piece of it too. So we'd like to take this one and move it forward to continue to work on this and hopefully bring it to back to the next session.
Are there any questions?
Madam Chair, there's no further questions.
Thank you, Jonathan. And thank you, Sherry and Tom, for jumping in at this point. I didn't realize until now that you're on my agenda at 2 different locations. So continuing on with your bringing forward these new advisories, I just want to make sure that the council is aware of the bullet points that you brought up and that you met in the list that we are required as subcommittees to meet. And that is, who is your audience? What is the end goal of the advisory or the recommendation? What action will you be asking the target audience to take? And is it in their statutory authority to take such action? Does federal guidance already exist for this topic? If so, is there a gap in the guidance provided for EMS? Will this advisory assist in closing that gap? And I believe you have brought forward the answers to those questions, but that is just to remind the council members as you're considering these advisories. The chair would now like to recognize Matthew Powers of the Professional Safety Subcommittee.
All right. Thank you, Madam Chair. And again, just like Sherry had said, what a humbling experience this has been for the past 5 or 6 years that we've been able to provide our expertise on this council. So we have 2. One is our first one that we've been working on for about 2 years now is a strategy to mitigate negative impacts to EMS well-being during public health emergencies by recognizing EMS practitioners as essential healthcare workers, as well as identifying the term pre-hospital in a healthcare setting. So that is going to be on the agenda for tomorrow for final, for the council's approval to move that forward to FICAMS. The second one we had is from, that was approved at our last meeting, was on crash scene safety for EMS responders. With that, we've done some brainstorming, and as part of this brainstorming will be passed on to the new, I guess the new council when they get appointed and come in. But we were looking at kind of on the crash scene safety, more looking at a global approach, umbrella of safety for EMS in general. So far, as part of our brainstorming, we talked about provider education, online education, also again looking at the roadway safety letter that Dr. Gestring and our team went ahead and headed up. Look at the past advisory from December 2011, looking at research lane patterns, vehicle lighting, vehicle type of mechanics such as that, protective clothing for and reflective vests. And then as we're talking about this, we need to look at more global for EMS safety systems in the just culture world and also in safety systems. We did ask from our last meeting, and thank you to Clary for our presentation for the whole council tomorrow on the traffic incident management, Tim's presentation, so we look forward to that. And then from there, we'll be able to then give our recommendations, and I'll meet with the new chair, whenever that is, for professional safety, and pass all that information on to them for their continuance. And that's all I have. So thank you, Madam Chair.
Are there any questions or feedback from the council members?
Just wanted to congratulate you and your committee on some really outstanding work on two very important topics, and certainly thank you for your years of service here and leadership and guidance. So thank you.
Thank you, Brendan.
Any other questions for Mr. Powers and their group? There's no further questions on the floor, Madam Chair.
Thank you, Jonathan, and thank you, Mr. Powers. The chair would like to now recognize Dr. Richard Bradley and the Equitable Patient Care Subcommittee.
Thank you, Madam Chairman. The Equitable Care Subcommittee has been working for a couple sessions now on equitable EMS response regardless of population density. And it's really impossible to achieve equal response. We're looking at heavily populated areas, urban and suburban, versus non-dense areas such as suburban and frontier. And clearly you're not going to get the same equal response in the two areas, but our goal has become making sure that the response in the more rural areas are as safe as we can reasonably achieve. And looking at the different types of things that we can look at, there's a number of measures as how we can look and see, are we achieving, or how close are we coming to achieving the minimum level that we would like. Part of that deals with challenges with 911 systems, which is being worked by other subcommittees in rural areas. There's certainly some areas where you can travel on a roadway and you are not in cell phone coverage, making it obviously very difficult to call for help should there be any type of emergency, including a traffic emergency. So looking at things like accurate dispatch to from a PSAP, intervals, first responder and ALS response intervals, and total transportation times to emergency centers and specialty care centers. There are a number of things that we can look at on how to address these needs. Again, some are being looked at by other subcommittees, so we're not going to address specifically. One, most importantly, being universal access to E911 from anywhere when you're traveling on a state or federal roadway. EMT and paramedic training, including training in rural settings, looking at the potential, again, not within our subcommittee, but recognizing that there are new ways of educating people who live some distance away from a training site. Further ways to support both volunteer and career EMS personnel. There's certainly areas of the country where per-use funding is not going to fund an adequate level of EMS response. And then also looking at how the country should address healthcare islands, areas in the country where there's either no hospital available within a reasonable range or no specialty center, such as a trauma center, cardiac center, or stroke center available. What we've looked at so far, what we found so far, is that there really is, beyond the empiric evidence, there still is significant shortages in the information we have. So as we continue to fine-tune our recommendations, they're really going to focus on ways that we would like to encourage additional research and ways to find out how we can best address these issues. So looking at things like manpower, cost-effective staffing models for first responders and ALS in the resource-constrained areas, and cost and effectiveness of eliminating healthcare islands for hospitals and specialty centers. So we'll continue to work on this tomorrow with our goal of bringing this to draft status. Questions?
I just have one question, or not really a question, just a comment. And thank you for addressing the issue of the healthcare islands. That, you know, rural America definitely is struggling a lot with this, and we see that in Colorado, where I live. And I think some of the information that you're addressing in your advisory does overlap with the one that we are moving to interim, and so I'll be happy to kind of share with you some of our background research to continue to help with moving your advisory forward.
Thank you very much.
Any further questions for Dr. Bradley? Madam Chair, there's no further questions on the floor.
Thank you, and thank you, Dr. Bradley. The chair would now like to recognize Dr. Kathleen Edelgeist and the Preparedness and Education Subcommittee.
Thank you. So the Preparedness and Education Subcommittee will be meeting tomorrow morning at 9. And in our planned meeting, we'll be reviewing 2 advisories that we currently have been working on. One we will be bringing back to NMSAC tomorrow afternoon for a vote to move from draft to interim status. And that advisory is entitled Ensuring Optimal Emergency Response via a Fully Integrated 911 and Emergency Medical Dispatch System. This advisory has undergone some significant edits and changes and revisions since our last meeting, where we introduced information specifically around national guidelines for telecommunicators and training of telecommunicators, specifically information around quality assurance and quality improvement work in that. We also did remove information from the advisory specific to identifying any proprietary dispatch system, as this was felt to be kind of conflicting information and not uniform. Overall, we have 4 recommendations to NHTSA. In the advisory, we have 1 recommendation of FICOMS and 1 recommendation to the Department of Transportation. The recommendations to NHTSA include convening and building resources to ensure interoperability of data systems across local, county, state, and federal entities. We also recommend funding mechanisms such as cooperative agreements to enable communities without Next Generation 911 to begin to move in that direction. Third recommendation is to incentivize the universal availability of emergency medical dispatch independent of proprietary system for both primary and secondary agencies that participate in emergency call taking and dispatch. And then our fourth recommendation in NHTSA is to develop and disseminate resources designed to reinforce the role of the telecommunicator and specifically to be recognized as a protected service occupation, which is within the public safety sector and moved out of the secretarial role. Our recommendation to FICOMS is to establish a plan of collaboration among federal agencies involved in community transition to Next Generation 911, such as NHTSA, the Federal Communications Commission, Indian Health Service, and others. And then our recommendation to the Department of Transportation is, as noted in the National Roadway Safety Strategy, the department should continue to support intergovernmental efforts to transition Next Generation 911 systems across the nation. We feel that the advisory is well researched, provides a good rationale, including issues of challenges in rural communities, specifically challenges about telecommunicators who have not had adequate training and the emotional distress that that puts on them, as guidance about why some of these recommendations are needed. Any questions about that advisory from the group? Go ahead.
I just want to thank you. It's an awesome advisory, and I'm just really pleased to see what you're doing for the 911 profession. So thank you for putting that forth.
Well, it's been illuminating to research this. The next advisory is still in the research phase. We don't have anything drafted for the group to consider, but we'll be discussing further tomorrow in our subcommittee, and that is the issue of preparedness in the event of for large-scale events. And we do have the audience of FICOMS and NHTSA. We do have recommendations around discussing the goals to gather stakeholders and build some consensus, build and update guidance because we don't have good guidance for large-scale events, include additional features in the guidance such as telecommunicators, public and private partnerships, and then also the concept of EMS reciprocity. And then we do have some federal guidance at this time, but it's quite old, and so that is the rationale for doing more work in this area. So we are looking to discuss this further tomorrow, in addition to the other couple of things that got added to our agenda as a committee, including wellness of EMS providers, as was discussed earlier today. So, so please come to that meeting, and we're looking forward to additional recommendations from the group. Oh, and it's been a real honor to be part of NMSAC for everybody.
Are there any questions or feedbacks for Dr. Edelgeist?
Madam Chair, there's none on the floor.
Thank you. The chair would like to recognize Alicia Sledge and the Ad Hoc Ambulance MBC Subcommittee.
Thank you, Madam Chair. Good afternoon, everyone. The Ad Hoc Ambulance Motor Vehicle Crash Subcommittee have been working to research an advisory regarding ambulance crash data and analysis. And a summary of what we've been looking to do, is or the goal of our subcommittee was to identify strategies to reduce the frequency and severity of ambulance crashes by enhancing opportunities for traffic crash investigations involving ambulances, which can be used for future development of countermeasures for the reduction of these incidents. A structured process is needed for identifying a consistent and unified method or process for which data elements are collected for ambulance crashes on a routine basis. It's difficult to determine the magnitude of the problem of the annual number of ambulance crashes, as well as the number of fatalities and serious injuries involved in these crashes, as there is no federal reporting mandate for such incidents. This is an extremely complicated topic with disparate information and inconsistent reporting across various state and federal entities. And so over the last 18 months or so, the subcommittee has been researching, talking with agencies that are involved in the ambulance crash investigation so that we can get a better picture of how these crashes are, or the investigations are initiated, what data elements are collected, what data gaps there may be, and trying to determine ways to improve on this process and the things that are currently required and needed. And we have several recommendations. The majority of them for the U.S. Department of Transportation and National Highway Traffic Safety Administration. And then we also have one for FICAMS. But for the USDOT and NHTSA, the recommendations include things such as developing a more consistent ambulance crash investigation reporting system, identifying required data elements to be captured in ambulance crash investigation reports, also creating a supplemental ambulance-specific database that's tied to the MUC, National Special Crash Investigation, by convening a stakeholder input group. Also working towards the adoption of using this new data template as part of the ambulance-involved crash investigations. We're also looking to recommend a determination of locations, crash types, and persons involved in the ambulance crashes, which include both ambulance occupants as well as the occupants of other vehicles. And also looking to recommend additional funding to expand, market, and support NHTSA's EMS investigation programs. A couple of other things, one of the things that is tentative or recommendations is to also look at asking the General Services Association to study the vehicle design structure of ambulances, including patient compartment areas, and to determine the inspection criteria of the vehicle, quality assurance procedures, and then how to improve the safety for ambulance occupants. And then lastly, for USDOT and NHTSA, recommending that ambulance-involved crashes for which ambulances are en route to or from an incident are required to have appropriate data elements incorporated into each of the state's traffic crash reports, and to develop recommendations on ways to improve the notification and assignment of these crash investigations. And then our last recommendation, which is to FICAMS, is to explore further state adoption and mandating of ambulance crash reporting for public and private agencies that receive federal funding of any form to report traffic crash fatalities, incapacitating injuries, significant property damage for occupants of the ambulance and other involved vehicles or persons, including weight crashes, which are like secondary crashes in relation to the response vehicles. So those are crashes that are occurring as vehicles are moving over to the side of the road, or also returning to lanes of traffic after an emergency vehicle has gone through. So looking at this under a quality improvement process, but also protecting the involved entities from discovery of findings during litigation. So as you can see, we have a broad area of recommendations and components that we're looking at in regards to ambulance crashes and the data collection and initiation of crash investigations. And so currently we've been researching that, as I said before, for several months. And we're working now on compiling that information and incorporating that into a draft agenda. So.
And Alicia, I'm going to interrupt you just for 5 minutes so that we can go to public comment, if you don't mind, and we'll come right back.
That will be fine. Thank you.
Thank you. Clary, has anything been sent to us in advance via email?
Nothing in advance, madam.
Are there any questions or comments via our web platform?
Yes, ma'am, we have a few. The first is continuous quality improvement managers in EMS continue to face significant challenges from hospital systems that are not freely sharing patient data outcomes. Even when the facilitation happens at the state level and state funded health data exchange platforms and software. The question is, there are two. Can NMSAC assist in encouraging hospitals' willingness to share patient outcome data with EMS? And the second question is, could NMSAC possibly also recommend legislation or regulatory action? I'll answer the second question. NMSAC is not a regulatory or has no regulatory or legislative authority and makes recommendations only to FICOMS and the Secretary of Transportation through the NHTSA Office of EMS. Anyone in the council, feel free to answer the first question. And again, that question is, can NMSAC assist with encouraging hospitals' willingness to share patient data outcome with EMS?
So I'd comment on that. I think, again, for the future NMSAC group, is to look at this from a data perspective and look at the integration of NEMSIS data with the healthcare exchanges and RIOs at the regional and local levels, which then enables our data set to go out. But if you have a two-way interface, potentially the ability to have data come in. And I know there's been, I think, some initial efforts on that at various communities where they have seen some success in being able to get the data from the hospital so we can understand the outcome side of things, as well as I believe NHTSA worked with a group to come out because one of these issues came up at a national data healthcare, public safety healthcare forum a couple of years ago regarding the misinterpretation of HIPAA and compliance around that. And so I believe there's a tool out there that you can use and download from probably the NHTSA website? NEMSIS website? Okay. That you can use to have help facilitate conversations with your local healthcare providers that may be hesitant to want to provide you that data because they're of a misunderstanding of HIPAA regulations. So that's a tool that was initially or intentionally built for this exact issue. So I think as these issues continue to arise, and it sounds like you've got some local challenges, we welcome this input so we can understand what else we can do to help lower the barriers here for exchange of data, because I think that it's vitally important to be able to link this outcome data to the work we do in EMS so we can truly understand our value, as well as provide feedback to our providers and practitioners for learning and also being able to say, hey, great job, you saved a life. So, thanks.
Okay, question number 2 from public comment. Can NMSAC help in removing any regulatory obstacles to telemedicine that may be expiring when the pandemic declaration expires? As far as the regulatory obstacles, that would be something that potentially CMS, who is a member of FICOMS, could address. Would the council like to address the question?
So it's my understanding that the telemedicine waivers are in place through 2024. I believe they were protected under the removal of the EUA, and that there was going to be some protection for telemedicine services moving forward. Does anyone have any information on that? I thought I read that.
I believe it did get extended. I don't know under which law. Is one of the only things that was not, I guess, that's not going to expire when the public health emergency is over. And that's because, we saw tremendous explosive growth of telemedicine during the pandemic, clearly shifted how the locus of care can occur for all settings in healthcare, especially in EMS, but many other settings as well. So there's a lot to unravel with that. I believe our advisory that we're working on actually does have a request in there for extension of any type of a public health emergency waiver that was given to EMS to be extended until we can figure out, the funding issues and everything else that's going on in our industry to help, facilitate whatever we can to continue to provide good care, but also get reimbursed for it. So, not sure if there's other waivers that.
I think it was specifically telemedicine and the home hospital program was being extended under that. So I think there is, obviously some focus by the government on the fact that these are important elements and they need to be continued. But to the point of the question, I do think that is something that as a council we should consider supporting moving forward. Certainly is integral for home care. It's integral for mobile integrated health care and all the other factors that go along with that.
Okay, and the final question received today was, access to pediatric specialty care and pediatric hospitals seems to be a problem. Could NMSAC address this?
Sure. There are several issues that we're working on, and I think that NEMSAC is well positioned to support that are happening nationally. After the report earlier from Mr. Srinivasan on the FICOMS update and the HRSA update, there is work to among states to support pediatric readiness, both at the hospital level as well as within the EMS agencies. And in fact, all state partnership programs were asked to develop and implement a pediatric medical recognition program for both hospitals and EMS agencies in the coming EMS for Children grant cycle. Certain states have actually passed legislation in this area, specifically New Jersey had passed legislation on this quite some time ago, is now finally getting some movement and some action on that after 30 years of waiting. And I do think within the Preparedness and Education Committee, tomorrow we can bring this issue up for discussion to both discuss how to potentially support EMS agencies in being pediatric ready, and then again, the same issue around pediatric readiness at hospital levels. When hospitals, as we saw in the respiratory surge, when community hospitals felt that low leveling processes relied on transferring to the local children's hospital, once the local children's hospitals became quite full, that entire process went out the door. They couldn't transfer and they couldn't take care of the children that they had because they didn't have the processes in place to be able to do it. And everyone was scrambling. So there's been national guidance on this for quite some time. And getting that information out to our stakeholders through the NEMSAC, potentially with advisories and other things, are things that we can discuss further tomorrow to kind of move this preparedness issue forward.
And that is all the public comment, Madam Chairperson.
Thank you, Clary. Ms. Sledge, we'd like to return the floor to you to continue discussion on your advisory.
Great, thank you. I think during my previous presentation, I've gone through all of the summary of the advisory that we're drafting, as well as the current or the tentative recommendations that will be included there. So at this point, I think we're ready to open the floor for if there were any questions in the room or online.
I'd just like to thank you, Ms. Sledge, for all the hard work you've been doing on this. This has been a slugfest over at least a session and a half of NEMSAC because it is a very, very complicated issue. There's lots of different entities involved in this, and just trying to fully appreciate what's needed and what are the right recommendations so that we can, I wouldn't say fix a broken system, but really more it's integrating, and then let's get some real research data out of it and let's use it to help build countermeasures and better vehicles and better safety systems, better training, and so on. So I just want to say thank you and then ask any of the committee members that are remaining or the future committee members to please, if you haven't engaged in this advisory, maybe you want to consider to do so, because I believe Ms. Sledge will be finishing her appointment through the end of April. And I know there's been a lot of hard work that's gone into this, and I think we're pretty close to getting it over the finish line, but I know some assistance might still be needed with that. So if anyone's interested, please reach out to her or Clary.
Great, thank you. And thanks for all of the other members on the committee, as well as the other NHTSA staff and other staff that have helped us over the past several months. Thanks, everyone.
Thank you, Ms. Sledge.
Madam Chair, we have a question on the floor. Mr. Powers.
Thank you, Madam Chair. So, I mean, really a lot of exciting work that Ms. Sledge has done with this. So my recommendation as coming off profession safety for the next term would be, as this closely ties into the safety piece, is to get someone that's remaining on that committee as part of the strategic planning talking tomorrow, by maybe putting someone on the future profession safety to assist with the new advisory.
Great, yes, thank you. I think that'll be a great idea. So hopefully we'll be able to identify someone either tomorrow or in the very near future.
Thank you, Ms. Sledge, and thank you, Mr. Powers. Are there any other advisories or subcommittee items that I have overlooked?
No one's indicating as such, Madam Chair, on the floor.
Thank you. To wrap up today, please keep in mind to consider the speakers that have presented, the topics, the items that have come up, questions that you may have about the proposed advisories, and any information that was generated through all your discussions today to be able to carry them forward for new advisories. This has been a very productive and informative day for everyone. And thank you to all the members of the public who have joined us today and given their input. Thank you to the subcommittees and their work on the respective advisories, and to all the council representatives for your participation and your continued willingness to serve as your sector's representatives. We will reconvene tomorrow afternoon at 1 p.m. There will be federal updates beginning at noon, 1 hour before our meeting starts. If there is no other business to discuss today, then I will open the floor for a motion to recess for the evening.
Motion to recess.
Second.
All those in favor? Yep, there's a motion on the floor. And all those in favor, if you would unmic and say aye.
Aye.
Aye. Anyone opposed, if you'd unmute and say nay. Any abstentions? Now's the time to voice that. The motion passes. Have a great evening, and we'll see you tomorrow.